Hello everyone, welcome back to Dermacoaching. That's my YouTube channel. And today I want to discuss a very interesting topic with you all, and the topic is nail biopsy. Now you might be wondering why nail biopsy. So very frequently we do not take a patient for nail procedures. So what would we need to do nail biopsy in this particular patient? Now have a close look at this particular patient. You can see that the patient is having crumbling of nails, there is onychodystrophy, there is onycholysis and onychorexis. In these two digits, if you very carefully see, there's a longitudinal splitting of the nail and a bit of pterygium-like formation. Although I'm not sure if it is nail lichenitis and nail psoriasis, but yes, it is having such kind of pterygium type looks. This patient has been having this kind of situation where he's having crumbling of nails, onychodystrophy, onychorexis, pterygium formation for the past 7 to 8 months. On multiple occasions, KOH was negative. Also, the patient was in treatment, fluconazole, for treatment of onychomycosis for quite some time, but he did not get any relief even after taking the treatment. Now, this situation is totally asymptomatic for the patient. But when he interacts with other people, he does not feel comfortable. He wants to get his diagnosis confirmed and then he wants to get the treatment done for it. And he wants to know if anything can be done for this thing at all or not. Another thing was that the patient did not have any body lesions. For example, if the patient would have been having a psoriatic patch somewhere, a papule of lichen planus, then we might have thought that yes, this is nail psoriasis or nail lichen planus, although the treatment or the management of nail psoriasis and nail lichen planus will not differ much. But yes, we cannot provide a confirmative diagnosis to this patient. Might be onychoscopy can come to our rescue, and the other way it out is doing a nail biopsy. So that is why nail biopsy was the option left for this particular patient. We do perform nail mattress biopsy if the patient is having longitudinal melanotic band to rule out subungual melanoma. But yes, can we perform biopsy for other problems as well? Yes, we can, but only if no other body lesions are present. As in this case, no body lesions were present. Now, why did we decide to do a nail bed biopsy? Why didn't we go for a nail mattress biopsy or a nail plate biopsy? So as you can see, the patient is having a lot of dystrophy. And we know that nail dystrophy means there's a problem with the nail mattress as well as the nail bed. Nail mattress biopsy is a more complex procedure and it can also result in a permanent dent in the nail plate. That is why we decided that we will go with the nail bed biopsy. As in this case, we perform nail bed biopsy. Let us go through the whole procedure step by step. What did we do and how did we perform nail bed biopsy in this particular patient? You can already see the mark. Yes, we chose the middle digit for performing this particular biopsy. Before doing any procedure, we have to take a consent. Similarly, in this patient also, we took a consent. And because the patient was not exposed to lignocaine ever before in his life, so a test dose of lignocaine was also given, following which the upcoming steps were performed. So before doing any procedure, we have to be sure that the surgical site is completely clean with the help of betadine and spirit. So we have completely cleaned not only the surgical site but also the neighboring digits as well with the help of betadine and spirit. Now the next step is giving anesthesia. What are the anesthesia that can be given for this particular patient? We can either go for plain lignocaine or we can go for lignocaine and adrenaline combination. Here I chose lignocaine. There are two ways of finger when we are operating on the nail. We can go for a proximal and a distal wing block. So here, this one that I am performing right now, this is the proximal digit block. And later on, I'll also show you how to perform a distal wing block. As you can see, my Needle, it is parallel to the finger. This is to anesthetize the neurovascular bundle. Make sure that you always withdraw the plunger before you inject the anesthesia so that you ensure that you are not inside the blood vessel. And then after withdrawing, checking that you are not inside the blood vessel, you can push the anesthesia. You can see that there will be slight bulge and distension that can be seen. So I'm withdrawing the plunger, checking that no blood withdrawal is seen. And now I will be pushing the anesthesia. You can see that slight extension of the digit can be seen after pushing the anesthesia at the proximal level. So this is the proximal digit block which is given at the base of the finger. It has to be repeated on the other side as well. So you can see I'm repeating the same steps on the other side as well. So this is proximal digit block which is performed at the base of the digit. This is to anesthetize the neurovascular bundle, the lateral neurovascular bundle. It takes some time to act. Here also you can see slight tension of the digit can be seen. So this takes some time to act. What I usually do, I perform both the blocks, the proximal digit block and the distal digit block. Both the blocks I perform. The next time is the distal wing block. What is the advantage of performing a distal wing block? That is very much quicker in action. Here we need to give a lesser amount of anesthesia. So you might have seen that earlier I had injected almost 1 ml on both sides. Here I'm giving only around 0.5 to 1 ml on either side. So again, you have to, give the anesthesia at the distal level, at the base, or might be the proximal nail fold, near the proximal nail fold. Again, withdraw the plunger, check that there is no withdrawal of the blood, and inject the anesthesia on the either side. Okay. Here I had to give some more anesthesia because some anesthesia came out because of the paronychia and the gap between the nail folds and the nail. Repeat the procedure on the second side as well. Withdraw and then inject. So after I have performed the block, that is the distal and the proximal block, I am doing the next step. I'm going for the next step, which is the exsanguination. How do we do that? So there are various ways of doing it. We can use a glove, or we can also use the simple gauze which is available in the OT. So we have to tie the gauze upside and down, and then remove the gauze again, and then tie a knot at the base. So tying the gauze from the upper portion to the downward portion, and once I reach the downward portion of the digit, I'm opening the gauze from the above, bringing it down, and then tying a tight knot. Okay. Why am I performing this step? It might be considered unnecessary by some, but I usually do it because it provides a bloodless field for us to operate on the nail. Next, I'm taking a punch to perform the nail bed biopsy. So obviously nail bed is underlying the nail plate. So whenever we do a nail bed biopsy, the nail plate will also come along with the nail bed. Sometimes the texture of the nail plate is so coarse that it breaks down, and in such a scenario, we have to send both the nail plate as well as the nail bed for the biopsy. I will show you the view from the other side as well so that you are able to see properly how am I performing the punch biopsy. So just like the normal skin biopsy, you have to stabilize the punch and perform the biopsy by doing a screw-like motion. So you can see the movement of my thumb and my finger. So this is screw-like motion. I'm stabilizing the punch with my index finger, and with my middle finger and the thumb, I'm performing a screw-like motion. So I'm giving you a view from the other side as well, so you can see how the punch is getting rotated like a screw. And after that, we can take out the nail plate and the nail bed. So you can see that this is the biopsy sample. Now we will be taking out the nail plate along with the nail bed with the help of the forceps. Okay. And obviously we have to transfer the sample into the formalin. We have to open the knot now. Remember, whenever you are operating on the nail and you are tying this knot for obtaining a bloodless field, do not tie the knot for more than 10 to 12 minutes. If the procedure by chance is extending for more than that amount of time, then open the knot in between, leave it for 2 to 3 minutes, and then you can repeat the same procedure again. Okay, so I will be showing you the sample now. You can see that the biopsy site, you can see that there's a small neck, and this is the biopsy sample, nail plate along with the nail bed. This is the place from where we have taken the biopsy. It is very clearly visible. And now we have to apply a liberal amount of the antibiotic cream. You have to tell the patient that there can be some seeded discharge for a few days. Tie the bandage properly. You have to give multiple levels of bandaging so that there is good amount of support that you're giving to the patient, and also because there's some amount of seeded discharge, so a good padding will absorb the seeded discharge. So this is how I perform nail bed biopsy in this patient. I hope that you liked this video and you were able to learn something from it. For more such videos, keep on following that channel. Take care. Bye.